G'day, and welcome back to episode 106 of the Sports Medicine Project. Thank you for listening, and thank you for tuning in if you've been here since the very beginning when we talked about dry needling being like Bitcoin. We were young and we're a little bit less young and a little bit less dumb now, but still cracking along. But before I get into this week's episode, I have to introduce my co-host, Kelly Kortik. How you doing, Kelly?
I'm good.
That's good. It's good to have you back on.
Back? Where have I been?
Well, you weren't going to do that episode last week. You were kind of a bit tired and you were like, let's just give it a break.
We recorded it 2 times last week and then we haven't used either of them.
Something
now
happened.
We're going round 3.
What did happen? We
were halfway through and then our friends came for dinner.
Oh, yeah,
so we
that's
paused
right.
And then we decided it wasn't very good. So we went for round 3 now.
Yeah, 8:30 p.m. is tough to record on a Sunday night.
I'm happy it's Saturday, and tomorrow it'll be Sunday Arvo, and then it'll just be nothing to do.
Yeah, the Saturday podcast. I think
I like a Saturday podcast.
You know why I reckon that is? It's because you have Fridays off, but it's closer to when you've had patients when you're in clinic mode or clinician mode. You know, when you go on holiday, and I say this every time this topic comes up, and maybe I just make it up in my head, but if you are working every day, you just seem to fall into these patterns. The analogies flow better. You just seem to recognize patterns a little bit quicker. Maybe that's what it is. Maybe it's a pattern recognition.
But I also think Sunday afternoons for me are just a bit sacred.
Yeah. You do love Sunday Arvo.
I do love Sunday Arvo.
And you got to recharge for the week.
Yeah.
You know, if you see, what do you think the average is? 50 patients a week for people? So maybe 12 to 15
I don't think that would be the average.
A day?
I don't know.
Maybe say 12 to 15 a day and times that by
12 to 15 a day?
Yeah.
I don't think that many people would see 12 to 15 people a day.
Well, let's say you work from 9 till 5:30 and you have, say, an hour for lunch. That'll be 7.5 hours. So you might have, you could have 15 patients if they're all follow-ups.
Back to back.
Yeah, but then you've got initials. There was times...
I reckon 10. I reckon 10 patients a day is average.
I remember in my second year still trying to see like 20, 23 patients. And I thought the more patients you see in the day, the better you are. And it was a horrible idea and concept to have. But I just remember booking people in and thinking, surely the quality of... I didn't even really think of the quality of care, but just thinking the more people I see, that's got to be better.
I do think I do better on a day that's busier though, when I can just go like bang, bang, bang. I somehow manage to get like all my notes done, write all my letters, see all my patients, and I'm way more productive than on a day that I might have like 8 people and heaps of gaps. Yeah,
there's a ceiling of how much I think you can see or how much energy you can give, because you might say back-to-back is great, but there'll be a certain number, I think, where it starts to then maybe affect just how much you can get up and how much energy you can give, how much empathy you can offer.
Yeah.
That's why I like the hour initials and 30-minute follow-ups. I know some people do 40-20 for the diary. I know some people do even longer than an hour initial. I've seen 90-minute ones. I think that's a little bit more NDIS, but I've seen 90-minute initials. That's a lot of time to spend with people, but seeing a few of those in a day really takes it out of you. Like if you have 3 or 4 initials in a row.
We've also got strength and conditioning sessions, or our performance rehab sessions, which are 45-minute sessions, and it's going into the gym and taking patients through their rehab program, like supervised. And because I know exactly what's going on, I know exactly what we're up to, it's usually quite predictable. I've got a plan in place. Having those scattered throughout the day or the week definitely makes it a lot easier, because they're like mates, like very easy to chat to them, know what's going on. It's not that whole like having to build that rapport, get to know them, work out what's going on. So that makes it a lot easier, I think, too.
Yeah, I enjoy going into the gym. I spend most of the consult in there going through things, or just re-educating or going through the same movement again and seeing how it feels. But it's good. You can basically just run it from the gym.
So this is the issue that I have with these new note-taking systems where they listen to you speaking, is that I spend so much of my consult not in my room. I'm like in the gym, or I might be in the hallway doing some jumping, and then I just jump around heaps. So how do you make that work? You just have to bring your laptop with you, and I guess it follows you.
You may not have looked into it enough, because you can bring your phone with you. and it will listen.
Not my phone because it can't hear me.
Yeah, not your phone, but literally any other phone on earth you could bring.
My phone's broken, by the way.
Yeah, but you'll be able to, if you're able to fix that, maybe.
If I just have my headphones in all the time, I can be multitasking. I can have my headphones in, treating patients, taking calls, like the barbers do for you when you get your hair done, and you're like half having a conversation with them, but then they're also talking about their next consult or talking to their mate on their AirPods.
Yeah, imagine that rapport. That would be pretty
Imagine
cool
if we did that. Like, sorry, let me just take this call.
All right, now we have no guests today. We're speaking about, as we always do, our clinical week, Monday to Friday, talking about some of the research that we've read, some of the webinars and presentations that we've watched. But before we get into that, we are a week late on the podcast, and the reason for that is we just do not have any time throughout the week. Kelly had a bone stress webinar, in-person presentation that she spoke out on Wednesday. I've been working at the uni and marking, which has really just taken most of my time and afternoons and nights, very late nights up. So we just haven't
Even
had
Monday,
time
it was
to
a
do
public holiday and we just had not a spare second.
Yeah, plus we're presenting in a course. It'll be actually the day before. So we've got the running room course, which is 5 of us speaking down in Sydney on all things running, which sold out, which is awesome. So prepping for that. It's just been really busy and trying to write some research papers and get some things off the ground, which has really taken up some time. But it's really enjoyable. We have added some things over to our Patreon as well. As we said last week, we've got we've got a fibroma research breakdown. We've also got a foot orthosis prescription and how that is done, the clinical reasoning behind that, plus the actual picture, and you can actually see the way in which it has come out from prescription to the orthoses. And it was quite interesting. It's probably the first one I've done where I've had a complete 100% success. So this person has been wearing it now for 4 weeks and has absolutely no pain, which is awesome. And the thing that I changed is I just made the deflection a little bit wider. You wouldn't see many fibromas, but I think the way they're reported in the research is plantar fibromatosis, but just think of it like a nodule, really common in the plantar fascia and the plantar surface of the foot, which can obviously become quite irritable if it's getting compressed or you're having increased tensile force on the plantar fascia. So custom foot orthoses with a deflection can work really well because it reduces the force.
Got to the root cause with that one.
Well, I tried to read as much as I possibly could, and it seems to be conflicting research. Some people say there is a hereditary component to it, something to do with like Viking blood all the way back.
Viking blood?
Yeah,
That's
apparently
cool.
because you can have them in the... I've got one in my hand called a
yours
Jupiter.
Is getting worse.
Yeah, mine is.
That's getting heaps worse.
Yeah, it's thicker because I've...
callous just on top of it, maybe.
Because I gym this morning. So I put some pressure in through there. But that one's in the one that I've got on my hand is on my left hand in my flexor tendon for my fifth. But obviously it doesn't irritate me as much because I don't put as much compressive force into there compared to the plantar fascia. And a lot of people can have them and they not be irritable at all. But this is a case where deflecting and taking the pressure off can really help. And a lot of the time for people, they don't really achieve... I don't think they always achieve 100% relief. They kind of feel it here and there. It's a bit like an old persistent kind of acute on chronic Achilles tendon where you have some low level stiffness here and there and it never fully, completely 100% resolves. But in this case it does, but it's only been 4 weeks. So that was interesting. So that's up on the Patreon, which is awesome. You did a 40-minute webinar on bone stress injury rehab. What did you talk about in that?
I think it was more 30 minutes, closer to 30 minutes, but it was more talking about the management side of things. So not necessarily going into risk factors and what a bone stress injury is and how they happen and bone physiology or anything like that, but purely talking to the management side of things. So kind of putting all of that sort of prior knowledge together into how we as health practitioners take a patient through from diagnosis to end stage rehab back to performance, and then also speaking to adjuncts, what are they, what's the evidence, and it is all very referenced and evidence-based. So put that all together and recorded that as a webinar, so that will be uploaded onto our Patreon soon too.
Yeah, that should be up by the time this episode comes out. That will be up. Link below. It is worth $7.50 a month. So it is a oat cappuccino with an extra shot in a month. So it breaks down to like $2.30 a week. I think it's around that, which is good. But link below, sign up to that to find some more stuff, and we'll be continuing to upload there every fortnight.
The webinar format was quite fun. I think I might do more of those.
Yeah, it's pretty easy to do.
Pop some slides together and talk to it.
Yeah. I had a thought about doing that, because when you create an Instagram post, you just can't have the nuance in there. Like, you can only have a couple of slides or a little bit of information, and you can never really explain things or even address some of the comments. So that might be an idea to just speak even through some of the slides as an idea.
It was also good because this was based off the presentation I did earlier this week to a big group of people where I had a shorter sort of time period. So for this, I could ramble, but also knowing it was going onto the Patreon, I threw a little bit of my own opinion and thoughts into it as well, which it's kind of fun to just unleash a little bit, you know?
Yeah, well, it's informed opinion from the evidence and from what you've read, so I think it's valid. I used to be of the opinion that everybody can have an opinion, but maybe not after.
No one's allowed an opinion.
Well, I mean, I just can't articulate it as well as what other people can, but this idea that if you have an idea and you have two people debating an idea, let's say, there is very likely to be one person on one side who's going to be more believable, and they have the evidence in their own favour of their life to say that. So let's say I'm speaking to Christian Barton about patellofemoral pain. So he is definitely going to know more than me on that topic, but I'm also going to know a couple of things. So I think we could both have an opinion, but his opinion is going to be more believable. But let's say I'm speaking to someone on the street, or I'm speaking to a runner who has a really popular podcast, and he's speaking about biomechanics and medical stuff. How much is the opinion valid if it's not going to be informed by current evidence or experiences?
I guess it depends on if they're talking about their experience and what they're feeling, because I think that's valid because that's what they're experiencing. But I don't think that you can comment on what that essentially translate to when we're talking to the general population or about the general population.
So let's take a really extreme example, and I can't remember the fallacy of what that is when you do that, but let's say that I believe that women shouldn't be allowed to vote. That's my opinion. Is that opinion valid? Just because it's mine. That's how I feel.
Sorry, I was sort of more meaning from the sense of someone saying, oh, my hip flexors are really tight, or they feel really tight.
Oh,
that's something that they feel and they experience, but that doesn't necessarily mean that it is true. Like, they might not actually have tight flip flexors, hip flexors. However, they have the feeling that they do. Is kind of more what I meant.
Yeah,
but I know
you might have missed the point of what I was saying. So I'm saying if you're having a conversation, so if you and I are speaking about something, and you're giving your opinion and your idea on a topic, should you be able to do that, I guess maybe in the public format, if you don't have the adequate experience or research to be able to do that?
I think that's the tricky part about all of this, is that it is ultimately coming down to, this is our opinion. Not every single thing that comes out of our mouth is evidence-based.
No, but it's evidence, but it should be evidence-informed.
But that's a grey line, though. That's
grey area.
Grey area.
Yeah. I'm not saying that, and we fall into that bucket as well.
So the people let's say that, going back to the runner with the podcast, their opinion is coming from a place of care and wanting other people to do better and feel better. So they're doing their best to educate the general population, I suppose. Which is exactly what we're doing. Yeah, so there would be things that we would say that we'd get wrong, I'm sure. Yeah, but that's not a reason. Just because you think you're trying to help people doesn't give you a valid reason to say you should be able to do it. So does that mean we should stop the podcast? No, because people like Squat U University. Yeah. Even if he cares about what he's trying to do, does that then make what he's trying to do right? It doesn't. No. So this is, and I've listened to lots and lots of Sam Harris and lots of things around religion and terrorism and what people believe, and it's a war of ideas. But just because someone believes in martyrdom or blowing themselves up, does that then make it right? And that's a very extreme example, but that's kind of the end of the continuum. So that's what I'm saying. I guess it's also like the recent podcast debacle with Stuart McGill on, whose podcast was that?
And Adam?
No.
Oh, E3 Rehab?
No.
Andrew Huberman.
Yeah,
exactly. Perfect example of...
So Andrew Huberman has seeked out someone who's an expert in back pain. But then there's a lot of other clinicians like us who are like, oh, that's probably like not a great person to have representing low back pain rehab. And so then... So they've come at it from a place of trying to educate people and help people. But people like us look at that and we're like, could have been better.
Yeah, but the reason we say that is the things that some of the points and some of the ideas probably weren't grounded in current up-to-date evidence-based guidelines or evidence-informed guidelines. I think that's and it is really hard. It's so, you get so much, I have imposter syndrome talking about it now because you try, and we both try so hard, we really do, to try and deliver the right information and acknowledge when we are wrong or when we've misquoted something. But I guess if you've got two ideas, you want to try and have one that is evidence informed and evidence based with current guidelines, because old ideas can still be presented if not too many things have changed. But yeah, it is difficult. So yeah, I don't know what to then conclude that with.
Well, I hope you've enjoyed the last 106 episodes.
Yeah, that might be... I don't think you can get cancelled off that, can you?
No, I don't think so. I think that was a good discussion, because it's true. You do your best to try and put something out there, and sometimes it might not be right, and you just need to be aware of that and making sure that you're aware of how that's coming across to other people, and if it is actually based on evidence, maybe you need to just be checking in on yourself. Not that anyone on him is doing that necessarily, but, the influencers who don't have so there is, I can think of someone in my head, there's an influencer that's just gone into running and is posting all this stuff about running and shit. And I'm like, fucking shut up.
Yeah, it's sometimes the information can be harmless, but it's even the people... I mean, I guess people would say the same about myself more so because I do more of the social media stuff, but I'm sure it's been said about the podcast. And I hope if it does, please reach out, because I've been listening to a couple of podcasts and so frustrating. I turn it off and turn it back on. There's this one where this physio is talking about strength training or resistance training. It's like, I hate people, uses the word, I hate people that say resistance training doesn't make you faster or it's not going to help your running. And it's like, have you read any research in the last 10 years to show how it improves?
It's not going to make you
not going to make you faster. So sacrificing any of your running is bad, and it's not going to make you faster. Where there is countless studies, up to 11%.
Oh, so wait, you said he hates people that say it's not...
say that, yeah, or think that. So if you think
I think you've said that wrong, but yeah. So he says there's no point to resistance training, basically.
Yeah, if you're a runner. If you're in a running block.
Said that the other way around.
Yeah, okay, thanks for clarifying. But there's plenty of research and plenty of quality research and systematic reviews to show that it improves time trial performance. It's great for building bone density. It is great for improving your running economy, how much energy, the metabolic cost of running, clearly, by percentage points more than what super shoes do. So stuff like that, even though you may be like, I'm trying to provide good quality information, but that information is just wrong.
Actually, I have an example of this too. One of my runners that comes into the clinic listens to another running podcast, and they were on that podcast talking about how strength training's not good for running because it breaks down your muscle too much. So it's not going to help with your running performance or your feeling freshness or anything like that. And I was like, what does that even mean? I can't even, I'm like, so what does running do then? Does that not break down muscle too?
Yeah.
It's tricky because they were so adamant, that was their opinion. I haven't actually listened to the podcast. I don't know that I want to. But there's just that temptation to be like, that's not good for a lot of people to listen to that.
No.
Let's talk about all the benefits that actually come from resistance training, helping with bone density, particularly when we're talking about athletes in sports where running isn't the best stimulus for bone, and stress fractures are quite common. Whereas some of the other benefits, even if it's not directly shown to help with injury prevention in running, it is going to be indirectly helping your overall health.
Oh yeah, the other health benefits from metabolic markers, blood markers, bone health, tendon health, cognitive health, adipose tissue, lean mass. The benefits are there is an also if you're wanting to learn more about it, there is an awesome open access systematic review that tried to correlate all the benefits together of all systems in the body, and it's great. But you can never really address all the information because it's so difficult, and there's so much of it. It's hard, but you want people to have good quality information, or just to have an understanding, a little bit of the nuance. So as much of the statement of everybody or resistance training is bad for runners, or resistance training is the best for runners, both those statements aren't really true, because it depends on the person and it depends on lots of different things. But it's just too hard to have those conversations on really anywhere but a podcast, which is good. But let's get stuck into the week. I can't believe we spoke for 21 minutes before we started bringing this stuff up.
I can. You love to yap.
I wasn't yapping. You were egging me on a little bit. And we spoke about terrorism, and it's like, this is a health podcast. Anyway, let's get stuck into your week. Actually, no, I'll start with my week, because I wanted to acknowledge I saw a lot of heel pain this week, and I had a case where somebody went somewhere else because they liked their approach more. So I want to speak about that and the way I tried to address it, and how it made me feel initially. Because we speak about a lot of the highs, and we speak about trying to always be better, and we always speak about this happening, but very, very rarely do you actually get the feedback. So I'll get to that. Mm-hmm. So Monday, I had someone come to see me with some pretty typical compressive heel pain that had been going on for around 9 months, and they had heard of me through a run club, and some people within that run club had similar conditions and come to see me and had done quite well. This person had been struggling for a while, and they had tried everything under the sun. Have you ever heard of someone having radiation before for a musculoskeletal complaint?
No.
So they were having radiation, which was interesting. I've never heard of someone having that for heel pain, which was interesting. But anyway,
helpful? No.
Not so much. Maybe a little bit, but it was over.
Was that under a physio or a sports doctor? Or
it was at a hospital. I didn't really ask much about it because it was a lot to unpack in the console. But and I thought that was interesting. I haven't seen that really reported much in the research. I've seen it reported for things in the forefoot, but not so much for heel pain. But anyway, so it was the only time that I probably imagine how people like Ebony Ray must feel when someone comes in and from multiple sources, you've got an alright reputation. So they'd come in, other people had said, yep, go and see Blake, he's not too bad, he's about to help you get back to some running. And this person was really ready to do it. And they kind of acknowledged, like, yeah, I'd heard from this person and that person, the hairdresser had said something. It was just really odd that they were kind of all in the same circles. So I imagine that's how like the really experienced, awesome clinicians feel, where people like fly in from other side of the world or Australia to go and see these people because they've got some tendon pain, and they're like, all right, this person's going to fix me. They are the best on earth. So that was a pretty cool feeling. So hopefully in the next 40 years I can get to that point. But interestingly enough, people that I'm seeing haven't tried any return to run programs. Like for a runner, that seems to be the first thing that I think of. Like out of everything, like have we just tried some finding the sweet spot and then progressing forward? So it had been a kind of boom and busting. Had a couple of times where they got back to some consistent running and then flared up again, stopped, rested, that kind of boom bust cycle. But the last run was 9 kilometers. And really didn't like that much load during and after. But before that had gone for 4 kilometers and things felt okay. So for me, just with that information, I was like, great, it probably is somewhere between 4 and 9 kilometers is your sweet spot. Let's just try and start there, give you a couple of days rest in between, and then let's change your shoes. Let's focus on some strength because it's unilateral and you've got some deficits on that side. And we just found that sweet spot and then move forward. And it sounds really logical, but I don't know if run programming... Do you think that's really common for people to understand? You definitely don't learn it at university, or do you think it's just common because we're both runners?
I don't know. I think it's more common for people to go to rehab, because if you're not a runner, that's where you feel comfortable prescribing exercises and jumping and hopping maybe, or just like calf raises or foot intrinsics or whatever it might be. I think if you're not a runner, that's probably where you feel most confident. So that's the recommendation that you're going to be making. But if you haven't had experience with working with runners and you're not a runner yourself, you might just forget that in itself is actually rehab as well. So there's that element that certainly needs to be discussed and picked apart, and then trying to find that perfect dose like what you've done. And yeah, maybe that is something that is missed or not done as well as it could be.
Yeah, so we brought it back to 4 kilometers because we knew that was okay, and we're like, we don't really want to push it much more because we've had a pretty long history, and we said let's just try and do that every 3 days. So run, have 2 days off, do the strength training on the same day, because any kind of resistance training actually felt okay, and we'll see how we go. Soften the heel up, change the shoes, and I think it should be all right. I wonder if it's just going to be a matter of acknowledging that it's going to take some time, and acknowledging that if there's nothing really to get back to other than we just want to be able to run consistently, taking a little bit more time is going to be better. But I said this to the person, like, I've got the benefit of hindsight because I already know what you've tried and that hasn't worked, whereas I'm going to try something different, and usually they're pretty open to that rather than doing the same thing.
For sure. Yeah.
Tuesday, 2 heel pain cases, quite interesting.
Oh, so that wasn't the one that left.
No. So this is on Tuesday.
I was going to say, you must have royally fucked that up if you had like a full-on referral network of people and then they still decided they didn't want to see you.
No, definitely not. Definitely not.
I feel like usually those are the ones where you don't actually have to do that much, and they will do better.
Yeah, there's certainly
the referral.
There's some contextual things happening there. So on Tuesday, so originally saw this person for some compressive heel pain again, which is easily the most common thing that I see. But this person had some shoes that probably weren't too appropriate, but I put something in the shoe that's nice and soft around the heel, and we had a really good response. I saw them a couple of weeks after, so this is the third review. So I had a really good response to the soft heel, probably improved by about 50%, and when they come in again, I was like, great. And I've done this before where something soft has made it feel better, so I just continued to make it softer rather than going, great, let's just see how that goes, continuing for a little bit longer because the trajectory is getting better. And I made it softer again, and then it made it quite uncomfortable. Come back in, adjusted it, fixed it up, and it was kind of comfortable, but it wasn't as good as what it was before. And I thought, I probably should just change it and really just strip it all the way back and kind of leave it how it was. But I kind of left it with a little bit more of a chunk under the heel, and the shoes weren't helping. But that was obviously uncomfortable, and they said, it improved, but I saw someone else, and I like that approach a little bit better. Which initially I was like, it was my fault for definitely my fault for not educating. I shouldn't have went more into that case. It was a really simple plantar heel pain, but it doesn't happen too often because I'm so worried about having an adjustment issue.
How did you find out that they saw someone else?
They called. So they were really nice, like, hey, it got better and things were going all right, but I saw someone else and I just like that approach better. So we always talk about this does happen, but we never get that kind of feedback. So they were really lovely, and they're just like, I just like this approach better. And initially, and I know this happens, and I'm like, okay, what can I do to try and make it not happen again? Because you want to be able to help people. And I'm usually pretty proactive of trying to refer out if I can't think that I can help. But I think it's going to be an education point and seeing how someone responds to something and really trying to help them understand that we can change this, but sometimes we take a little bit of a risk of making things softer or making things more supportive. And unfortunately, that is the risk.
Yeah, I wish we got feedback like that more often, because what it does is it helps you realize that there's other ways that people get better as well. So if you're only seeing the people that come back, then you're thinking that everything that you're doing is helping because they're the people that you're seeing. But then the things that you try that don't help, often those people will deselect and not come back. And so you're not getting that information that what you might have done that time maybe wasn't helpful for that person. So there's this ongoing bias where everything that you do feels like it helps because that's the people that return. And it's hard to keep track of the ones that might deselect. I mean, you can make I try to sort of look at my list of people that cancelled or didn't arrive for the week, and then I'll check that again each month. And I'll make, I'll either email or I'll try to call people that aren't in my diary who I didn't officially discharge. to try and get more of that feedback or information from them. But more often than not, you just don't hear back from them.
Yeah, and a lot of the times they self-discharge because they're going
They're
okay,
better,
or they feel as though they can self-manage, which is great as well.
And then you don't hear of them for like 18 months, and then they book back in your diary, and you're like, oh, that's this person again. I thought that something might have happened, but apparently they just got better.
Yeah, it's interesting because it really changed. Well, it changed my perspective because for the rest of the day, with every person, I'm like, I was just a little bit on edge. Like, all right, we really need to make sure that you understand what's happening and what I'm doing and why. But I think it's a net positive, and it was a compressive heel pain, and it was doing better. So it wasn't a red flag one that we've missed, like a stress fracture or something really odd going on. But I think those things that are good to happen in your career, and trying to minimize it is of course the goal, but it's good. It makes you think more, and it makes you reflect more, and it really just brings you back down to earth where sometimes you need to be.
Yeah, and it's also worthwhile remembering you can't be everything to everyone. So yeah, there are always going to be those cases where people just gel better with someone else, and it's okay to be okay with that.
Now, Wednesday changed up. All the podiatrists listening to this are going to really, really resonate with me. Physios, doctors, surgeons, probably not so much. Blisters are usually not too bad to manage, but some people in the population, it's a very small percentage, just have a genetic predisposition where their skin is more sensitive, and they usually deselect from the sport or activity that makes them blister. But some people just really struggle, and to their credit, they persevere. So like netballers and runners, but it's all someone that really has some really sensitive skin, and just blisters at the slightest bit of pressure, not just on the foot and the ankle, but basically all over the body, wrists and hands, struggles with watches and rings and things. Yeah, just the skin's more sensitive. So trying to manage apical blisters, so blisters on the ends of the toes, and that area is pretty high pressure. If your toes grip a bit, push into the end of the shoe can be challenging. But we use things like the Lengo patches, trying to maximize shoes, using pads just behind the toes to try and lift the toes up, using little toe sleeves, wrapping them in Coban can really help. But a lot of this stuff just takes so much time. Like, you imagine you're going to go out for a 5K run and you've got to wrap all the end of your toes, put these little pads in, and you might still get a blister, but it's just not as bad.
Because I have to do that sometimes before long runs, because I feel like I'm quite sensitive in the skin for longer runs.
Yeah, you do, and you get some of that pinch blister on your fifth toe.
Yeah, I've got a little mohawk on the bottom of my fifth
toe. Yeah, but for you, like, it's a good example where yours is calloused over. So for some people, it fills with fluid and it rubs and opens, and that has happened to you before.
Well, that happens when it goes longer. So then, I'll have to set aside time to band-aid up my feet or whatever before a long run, and I often think that I'm like, gosh, this is time consuming.
And it's frustrating for people. Like, you think of all the potential musculoskeletal complaints that can limit you. Blisters are just a real frustration.
Ever recommend, because what I've been doing lately before long runs is I just rub Body Glide all over my feet, and it actually helps. Do you ever recommend that?
Yeah, you can use Body Glide. I mean, usually the other stuff is a little bit more effective.
What's the other one?
So not cream, but things like Engo patches and Coband and things like that. But yeah, you can do that as well. I find that stuff can work for the minor ones, but for people that have like
chronic blistering.
Yeah, chronic blistering, and they kind of blister on each other. They're real frustration.
Yeah, now, that would be tough.
Yeah, Thursday had a really good conversation with someone about an Achilles tendinopathy, insertional Achilles tendinopathy, and at this stage, being happy with low and stable symptoms, and being happy to give it another 3 to 4 months of going through all the consistent rehab that we've been doing. So, jumping and heavy calf raises and doing some running. And they were really open and just said, yeah, I'm happy with how it is at the moment. I still get some stiffness in the morning. I get a little bit of stiffness over the day. And if I really push it, I get a little bit of stiffness, but it's no more than a 2, and it never really gets above that. And they were pretty happy to let it go for another 4 months and see how it goes. So I wanted to ask you, because this would happen quite a lot for you with other tendons in the lower limb, do you typically check in on them in a period of time? So let's say, for typical research might say for an Achilles tendinopathy, anywhere from 6 months to 2 years. There's some studies show 40% of people can have pain at 5 years. if you've seen someone and they're back doing everything, they've got low and stable symptoms and they understand what's happening, are you reviewing them again, say in 6 months or 3 months or 4 months, if they're happy with how it's going?
I kind of ask them and work with them. So I'll say, look, we're at a point now where your symptoms are low and stable. You're back doing your sport. You know how to manage this. If things flare up, you know what to do. You've got all those tools in your tool belt. What do you feel like you need from me now? So options would be, we can check in 3 months' time, give you a little bit of time to just work through this and see how you're finding it. We'll have an appointment there. We can discuss anything, retest a few things, maybe give you some further progressions, and then carry on from there. Or do you feel as though you're happy to float at the moment, and if there's any dramas down the track, then just give me a call and they might just decide. I find a lot of the time for these ones who have followed through that extensive tendon rehab program, they're often pretty keen to check in about 3 months or so. So I'd say more often than not, they would say, yeah, let's put something in a diary for 3 months and we'll check in then and see how things are going. Few would say that they're happy to float along.
Yeah, and it's good to see how, even for your own clinical experience, how they go. I mean, you can't really say that it's clear research of, yeah, they eventually all get better. But I find it interesting to see, has it improved much in 3 months, or is this really the best it's going to get within the 12 months? And and it's good to find the minimum effective dose for exercise, because people with these Achilles injuries, I'm recommending that they keep some good quality tendon and calf capacity building exercise in their routine for the foreseeable future. Now, Friday, posterior tibial tendon.
We were talking about this not long ago.
Function, in a male.
Yeah.
A male runner, which is really interesting, and I just don't think it's that common. I know the literature that I tried to read yesterday said that it is more common in females. There seems to be some soft tissue, menopausal, hormonal stuff, I think, involved in that and the changes, or something traumatic that causes a progressive change. But it's for me, I just don't think it's that common. You said it's not that common either.
No, I don't think I've seen someone. I don't think I've seen a male with it. Maybe a handful. But I don't even know if it was like tib post dysfunction or if it was more like just a tib post tendinopathy.
Yeah, and the goal is to run a 50k, which is going to be really cool. See how we.
That's tough because I'm assuming that's on trail.
Trail, yeah, and I think it was stage 2A, so still flexible, but a bit of pain laterally and pain medially. But interesting when it comes to shoe choice, they were in a Mizuno shoe. Now, Mizuno shoes are generally pretty good, and the new versions are definitely better because the plantar midsole is a lot wider now. But one thing with these kind of foot posture related, or you think foot posture is playing into the provoking discomfort or provoking movement for them, making sure they have a shoe where it's wider through the midsole, because they're going to have wider plantar pressure distribution with their foot because they're going to have more surface area contact. So having a plantar gauge that's wider is going to be really helpful and really make them feel a lot more stable. So if you just turn over the shoe, looking through the midfoot for a runner or for someone that wants to do more walking, just make sure that it is wide through there, because if it's thinner, they basically fall off the shoe. So even if it's a really high pitch shoe and it feels great, still having that is going to be really helpful for them.
Yeah.
Which is good.
Cool.
You read any cool research this week?
Yeah, I did, because I had this presentation, and it wasn't, I guess it was over the last few weeks, but I've just read so many studies on bone stress injuries over the last few weeks, and a few of them stood out to me. I guess I could just rattle off a few little
hit it with
one-liners.
Yeah. That's what people want. Facts.
And
you can have an opinion too. It's valid.
Decreased knee extension strength.
Yep.
Increases your risk of a tibial bone stress injury by 5 times.
That's interesting. This is in a military population. I remember you telling me this.
Yeah. So the reason being that if your quads start to fatigue, then it's going to be loading your plantar flexors more, which therefore could increase your risk of a tibial bone stress injury. So when you are dealing with patients with a tibial bone stress injury, or a bone stress injury that is around the plantar flexor loading region, so tibia, fibula, metatarsals, it is also very important to test knee extension strength, because that might be risk factor, or I guess a hole that you could plug during that rehab period.
Yeah, I wonder, it would be cool if they could then do an analysis to subdivide that into unilateral or bilateral, and then again subcategorize if they did some pre-military training testing to then see if your left is weaker or there's this cut off for strength. I really wish we did have some value, but it's just too hard to make with people.
Another one that I read that was interesting, and there might be some flaws in one of these papers in particular, but there was 2 randomized control trials, one looking at tibial bone stress injuries and one looking at lumbar spine bone stress injuries, so in fast bowlers. And they both showed that the peak loss of bone mineral density was roughly around the 20-week post bone stress injury diagnosis. So the bone stress injury has been diagnosed, say, in January. The peak loss of bone mineral density is around June,
yeah.
May, June.
I've been reading a bit about bone mineral density and the different tests and scans you can do, and one is the QCT, but it's high radiation, but it's a way better test, and there's actually quite a few flaws with bone mineral density testing.
Yeah. Well, that's what I found out when I was looking into these particular RCTs, is that it's a hard thing to sort of test and actually be certain about. I think from a physio perspective, my biggest takeaway from it was that there probably should be an emphasis on carrying through with rehab programs a lot longer than just getting a runner back to running. So there's enough in that for me to say that it's important for runners to follow through with any sort of osteogenic loading and continuing to fuel well and recover well for a much longer period of time than what they might think.
Yeah. Let's get stuck into the week. Monday, rattle us off.
So on Monday, it was actually a public holiday, so I reckon this might have been from last Monday.
Oh, yeah.
But I had a runner who had been doing some performance rehab programming with me.
Performance rehab?
That's what we call it. Yeah, it sounds pretty elite, doesn't it?
Yeah, that's so good.
Yeah, so coming in
I want to do that.
each week for 45 minutes, where we go through a strength and conditioning session where it's progressive. I'm giving them some things to work on at home as well to complement that. And they went for a hike on that weekend and a trail run, and just commented on how much stronger they'd felt. So their legs just felt like they weren't fatiguing as quickly, and it was just really clear evidence of how that extra intensity throughout the week can have such a good benefit to them. And I guess there's like a heap of other things that could be attributed to, but they were attributing it to the strength training, so I thought that was pretty cool. Felt quite rewarding.
Yeah, it's good. We had a conversation a couple of weeks ago about the frequency, and what I've been reading, I'm sure you've been reading as well, especially in the BSI world, but even in some of which Brad Schofield's a good guy to follow on Instagram. He posts some great stuff on resistance training, but it seems to be that 2 sessions a week is probably enough to get all the benefits that we're talking about. I know we spoke about 2 or 3 or 4, but 2 seems to be kind of the minimum effective dose. So you can get all these benefits from far less, and also the patients you're seeing get the benefits as well.
It's really interesting thinking about, there's like two schools of thought. It's either the minimal effective dose or the maximal recovery needed. So it's like, how much can you do making sure that you're recovering? And then it's like, what's the smallest amount that you could do to still get a benefit from it? And it's funny with running, because you're balancing the two. It's like, what's the minimal amount I can do in strength training? And then what's the maximal amount of running I can do but still recover from it?
Yeah, it's hard.
It is hard.
It's hard. I mean, if you've got time, that stuff really does matter. And I love speaking about what are these little nuances and what's going to be best. But clinically, it just matters about the person of like, hey, do you have 2 kids? Are you training for a marathon? Are you an elite runner and you have all the time in the world? Well, things are like, that's what it really matters about. Like for you and I mean, we can really just train whenever we want. It's more just the motivation, whereas
whenever
colleagues,
we want, apart from the 10 hours a day that we're working.
Oh, yeah. But I mean, we can't finish work at 5:30 and go, great, what am I going to do tonight? I'm going to go to the gym, I'm going to go for a run. I don't have to really be anywhere until 8 a.m. the next morning. But if you've got kids or family, it's a bit different.
Yeah. I'm listening to a podcast series at the moment about the women's marathoners who are all in their block leading up to Paris Marathon, and listening to their week and their life. It's like run and then go home to hang out with the kids, have some food, have a nap, and then run, and then I'll do some Pilates.
Yeah.
I'm like, that sounds nice.
They do have the time.
Tuesday, I've just had a few patients of late talking to me about incorporating peptides, and they're asking me for advice, and I don't know anything about peptides and their influence on your body, and if it's safe and all of these things. And it's weird that they feel like I can give that sort of advice. I don't even know who to recommend though. I mean, I guess they get them from a GP, right?
Yeah, it is. It is a GP, but I'm sure that they have to have some extra, maybe they have to advertise a speciality or some training. There is somebody in Newcastle, but I cannot think of his name, that advertise that they specialise in that kind of longevity space.
Yeah, right.
Yeah, and I've seen people talk about them online. I have read some studies on them and also on SARMs, but I'm definitely not going to talk about it on this podcast because I have absolutely no... I'm not even going to say they're good or bad because I just don't know much about them, but I know people in the NRL have been popped for them. They're pretty common.
Are they illegal?
They're not common, but they have definitely had people suspended for years.
So it's a performance-enhancing drug?
Yeah, depending on the type. So SARMs and peptides, I'm just speaking about SARMs here, but definitely both of those are performance enhancing. I mean, some of the bloody protein from Musashi is...
True.
Not from Musashi, but some other proteins are classified as...
It's not WADA approved.
Yeah, performance enhancing. But I know for SARMs are originally, or some of them were developed for people that have like severe muscle wasting due to like metabolic diseases or systemic diseases, and you can have them to try and maintain lean muscle. So if you're trying to build lean muscle or cut fat and keep lean muscle, it's a pretty good idea.
It's interesting. I reckon it's either going to go like one or two ways. They're either going to ban them and they'll be completely illegal, or it might become more and more common and you might be hearing more about it.
Yeah, I've had SARMs before because they were legal. So what happened, this is when I was 22.
Yeah, I remember it used to taste like soap.
Yeah, you used to get on the SARMs,
No,
hey? You
I
already know them. You were always racking them up. No, I'm kidding. What would happen is you could buy them legally, and then they got banned for a year. Then they come back, and that's when I stopped. I stopped taking them after they got banned. But then they come back as food additives, so they fell under that regulation, and then they got banned a year later again. And then I haven't been able to buy them.
What did they get banned for? What's the harm?
I think they were just unsafe. Like they didn't meet the FDA regulations. A bit like peptides.
Right.
Or it falls under the same, very, very broadly, the same category of steroids. Like we don't know enough about them. There haven't been any trials in people that aren't sick, really.
Did you notice a difference when you took them?
Oh yeah, I was buff. No, I did notice a difference in how like time to exhaustion. I just felt pretty fresh. I felt more fresh, which was cool. But I don't know if it was placebo too, because when you're early 20s and you're studying and you're at uni and you're taking something and you don't have much money, so you're putting all your eggs in this basket, you're like, oh yeah, this is definitely working. I remember anyway, not for a health podcast. Talking about like the training and stuff, that like the horrible principles that we used to believe in.
You weren't running then either. It would be interesting to see if you could run a fast 5K.
No way. And I was running in like minimalist shoes too. Remember those shoes that they gave me ITV?
They gave me ITV too.
You didn't have the same shoes though, did you?
Yeah, we were running the same shoe.
The
Beta Bay, that Beta Bay.
ASIC,
Yeah.
what was it? DS Trainer.
That's the one.
Yeah. And I remember, anyway, next topic. Wednesday.
So Wednesday I did my bone stress injury presentation to our local physio network. So it was a room full of physios, GPs, sports doctors, orthos, and I put a lot of time and effort and energy into developing that presentation. And
chiros, massage therapists.
Oh yeah, everyone, the whole lot. And I learnt so much in the process. That is the exact thing that I will avoid like the plague, having to do those types of things. It's obviously very uncomfortable. It puts you outside of your comfort zone. It's a scary environment, but there's so much benefit that comes from it. And I encourage you to put yourself out there and to force yourself to try and put a slide together where you are having to dive into the research and make sure that your information is all very evidence-based and clinically relevant, and practice presenting it, because you are going to learn so much in the process. So I am glad that I took that opportunity on and did it, and I am now also happy it's over.
So you're saying that trying to synthesize information to then present that to the public is beneficial. Is that what you're saying?
I know where you're going with
I'm just asking if that's what you're saying. Is that what you're saying?
Yeah.
Okay, that's interesting. That's really interesting. That's good. No, I know that we've had this conversation a lot.
Blake's trying to get me to step it up on the social media.
Bit of content. Well, it doesn't bother me anymore, because we've
gone separate ways.
Yeah, we've had this conversation so many times. Like, just do one post, just do something for me. Just speak in front of the camera, because I know you've got so much knowledge, but it does make you have to learn, though, because you feel it's this weird kind of, you feel as though that people are going to either question you on it, which they always should whenever there's information presented on health stuff. So you feel as though you need to go and understand it as much as possible, and the pros and the cons, so you can acknowledge it. And I find a little bit of that happening with the social media and with the podcast as well. It's like,
I have to say, though, it was time consuming. There's a lot of time that goes into doing that.
It is. And there's so much time that goes into that you don't actually see in the slides. Like, hey, you might have this one point of, bone mineral loss is at its highest 6 months.
Reading and dissecting
papers. Yeah, which is interesting. I mean, that's the whole part of learning. But then once you learn that information, you continue to build on it, which is cool. What about Thursday?
Oh, I just think, isn't it cool how we have gotten good at clinical reasoning across the years of working? So we've read lots of research and we've seen lots of presentations now to sort of know when something's a bit weird and it's not really fitting into a particular box. So you kind of flag that as being like, oh, going to refer on quickly if that doesn't improve, or, oh no, that sounds pretty mild. Like, that fits that pattern that I've seen 100 times before. It's following these sorts of inflammatory patterning or whatever it might be. And we just use all of that, those little bits of information, and we just funnel that into a funnel to come out with a diagnosis at the end after we've done our assessment. And we just make it make sense in our head. It's just so cool that we can do that. Like, we've developed that skill to do that. Yeah,
it is pretty cool. It takes time. But I mean, as humans, we're made to recognize patterns. That's how those optical illusions and things work. But you're right. You can hear someone's history and you're like, this sounds like this, and you really just seem to be confirming that with the other stuff in the back of your mind. Like the typical, someone comes in with heel pain, like, oh, yeah, it's worse in the morning. It's usually worse after I've sat down for a while. It's better in shoes. But I kind of feel it more on the inside of my foot, and it feels more like burning and numb. And you're like, oh, that pattern isn't typical of plantar heel pain. Maybe it's something more related to the tarsal tunnel or the little calcaneal nerve.
Yeah,
do you recognise those patterns?
I had an interesting one that made me write that. It was a younger female who does a lot of like jumping, like cheerleading type of sport, and was getting anterior hip pain, and it just came on quite suddenly, and they'd been increasing their training load due to competition, and straight away in my head I'm like, oh, I'm going to send for an MRI if I can't work out what's going on here, if even there's like a hint of this potentially being a neck of femur bone stress injury. Wasn't getting any night pain and didn't have any other health issues that might make me suspicious of a bone stress injury. And then, but I was like relying on my physical examination to either sway whether I was going to send for an MRI or not. And had no pain with jumping, no pain with hopping, and I got her hopping heaps. I was like, anything, no problems. really like wound up her hip range of motion and tested all of that. There was like a little bit of soreness at end range hip flexion, but then quite sore into like any resisted hip adduction. And when I took that onto stretch and got her to resist into hip adduction, that was really provoking her symptoms. And so from that, I was like, oh, I actually think I've got enough information here to say that this is more like an adductor-related groin pain rather than anything nasty like a bone stress injury. And I was like, that's just so cool how I can funnel that through.
Yeah, it is cool. And you never really get 100% of the... Well, you never take all the information and you're 100% sure, because there's always a little thing. And in your mind, you're like, oh, I guess if you stress it this way, it could be that part of the bone. But yeah, it is pretty interesting.
Yeah.
It is cool. And you're just kind of playing the odds a lot of the time. Yeah, it's good.
I don't work on Fridays, but I want to talk about the fact that I got 2 new pairs of shoes this week, both Saucony. Put them on my feet. They just feel like an absolute dream. And I think that could be my brand, maybe.
Better than the Mizuno shoe?
Well, I do love the Mizuno Wave Sky 7. So good. I still will love that shoe. I'm sad that shoe is approaching retirement. I might get a couple of little runs out of it still, but I think that one's pretty well had its time. But I am excited to break in these new shoes and for them to be the new OGs, because I've done 1 run in each of them now, and I'm a fan. I've currently got 11 pairs of shoes on my Strava, and I don't know if I'm embarrassed or impressed.
Yeah. Oh, well, you just got shoes. I mean, you do a fair bit of running. Makes sense.
Yeah.
Very good. We'll leave it there.
Oh, wait, there was one thing that I did want to add. I don't know if I was just going to say that